So good evening, everybody, and welcome to what is, I think, a significant event in Cambridge. It's the first in a series of dialogues that I'm launching about some of the most difficult issues of our time. And there are two purposes to what we're doing here. First, we want to see whether we can find common ground between people who may seem very far apart in their beliefs and opinions. If we are to make progress in legislation or in understanding the world we live in, we need to identify where we agree as well as where we disagree. But second, we believe that discussions must involve the widest range of viewpoints, that nothing within the law is taboo, and that freedom of speech and of thought and of academic debate do matter. You may find some of the views expressed in this series and here today personally distasteful, but I firmly believe it is better to hear them than to shut them down. We have the right to disagree, but not the right to insist that only our view must prevail. And tonight, we are tackling literally a matter of life and death, the question of whether assisted dying is compassionate or dangerous for society. So let me briefly explain how this evening will work. I'm joined by the Master of Selwyn College, Roger Mosey, a former BBC journalist, who will begin by interviewing our three main protagonists, who I'm going to introduce in just a second, and we'll launch a dialogue between them. Then I will bring in questions and comments from all of you, our audience, here in the auditorium. It's worth noting that this is not the Cambridge Union, much as we love it, that this is not about rhetoric and debate and winners and losers, but instead it's about understanding more, while at the same time hearing robust and honest views about a vital topic. So our distinguished speakers are, from left, Dr. Jonathan Romain was appointed Chair of Dignity in Dying, the UK's leading campaign for a change in the law on assisted dying in June of 2023. Next is Dr. Amy Proffitt, who speaks for Dying Well, the group promoting access to excellent care at the end of life and standing against the legalization of assisted suicide. And then we have Dr. Zoe Fritz, a Wellcome Fellow in Society and Ethics at the University of Cambridge and a consultant physician in acute medicine at Attenborough Hospital. She works with colleagues in the faculties of law and philosophy to ensure solutions are philosophically grounded and legally robust, as well as clinically practical and acceptable to all stakeholders. And I will now hand over to Roger, who will begin our conversation.
Vice-Chancellor, thank you very much indeed. So I will be interviewing each of these three people on the panel for about 5 minutes each, and then we will start a dialogue. And then, as the Vice-Chancellor says, we would love to have your questions and comments. So Jonathan Romain, as Chair of Dignity in Dying, why should people have a right to assisted dying?
Well, we all like to think that we have a right to a good death, and to live as well. A good life, and to live as well as possible in harmony with others. We choose our own career, our marriage partner, where to live, what to study, which college at Cambridge to go to, and why does that not extend to perhaps the most important part of our life, or one of the most important parts, which is our death? And particularly, and this is Dignity in Dying sort of mantra, or strapline, if you are dying anyway. In other words, we're not talking about someone who's depressed or mid-40s having a bad time, but someone who is dying, and they've got a terminal illness, and many of whom, by the way, will then continue to their dying breath. Good, great, and we'll give them every support. But some of them will want to actually let go of life, particularly if they are in unimaginable agony or pain or suffering greatly, and who don't want to live. And I have had so many people, because, as you may know, I'm also a congregational minister of faith, and therefore I visited a lot of hospitals. I've come across, and I guess a lot of you must have come across this as well, people say, who are in that situation, terminally ill, in pain, saying, why can't the doctors help me? Will you help me? Will you do something like suffocate me or whatever? Will you let me go peacefully rather than having to drag on for another 3 or 4 weeks?
But it does change the fundamental thing that doctors are normally there to keep us alive and to keep us healthy. In this case, you are asking doctors to kill people.
I'm not. It would only be the person themselves. And when we say, and this is a very important point, thank you, there's a big difference between suicide, euthanasia, and assisted dying. Suicide is when you kill yourself, and had you not done so, you may well have carried on for 30 or 40 years. Euthanasia is where someone else kills you. Assisted dying is where you yourself take a medical potion that will end your life. The only assisted bit is that you go through a doctor and you get a prescription, and then you yourself have to take it. And that is absolutely critical. Three things: assisted, that it's the person themselves, of sound mind, so not someone with Alzheimer's, but a sound mind, and wills it and is dying anyway.
Isn't the problem with what you said, and I'm sure Amy will develop it, that in every country which has legalised assisted dying, there is what people call the slippery slope argument. So it actually starts off, as you said, of people who are terminally ill with very short time to live. And then it becomes a more general application to people who no longer want to continue living, including in one case in Belgium recently, someone who suffered from depression and was autistic and was granted the right to die on that basis.
Yes, and that's a terrible aberration, and that's exactly why we wouldn't do that sort of law, and why just because Belgians do it doesn't mean to say the Brits have to do it. I mean, after all, Americans drive on the right-hand side of the road, doesn't mean to say we have to. This would be a British law for British people according to British values. What you haven't asked me is why I changed my mind, because I used to be against assisted dying, as like most ministers of religion are, for the usual sort of standard arrangements. And then I saw more and more people suffering until one day, and this was the tipping point for me, I went to visit someone who was dying in his hospital, or actually hospice, and he was in such pain that he was actually lying on his bed, on his knees, head down, because this was the only way he could actually, in bed, control, a certain extent, his pain. And I began to think there must be another way to do this better. And then I read about what was happening and the Joffrey Bill, which had all sorts of safeguards, that it had to be terminally ill, it had to be someone who was in pain, it had to be of their own will. And then I read, and this was another point, what was been happening in Oregon. In other words, although this is new to us and sounds quite radical, actually in the state of Oregon it's been happening for 25 years. And we have evidence, and this is really key, we have evidence of how it works, which is very successful, and that it has not been a slippery slope at all. And we've got 25 years of evidence, quarter of a century of scientific material. That is phenomenal. And Belgium, you see, to answer your original question, started from a different place. It did not have that tight control of terminally ill. And therefore, that's why we're not going to go down that route. We're going to do what's done in Oregon, and actually in so many countries around the world. And by the way, every single country that is, or state, that has introduced assisted dying has not taken it back and thought, oh no, this is not working, it's terrible, there's a slippery slope. And there's been no slippery slope. The only difference is the starting point, and we want to have a very tight starting point.
There are plenty of issues we can pick up later. Let me ask you a final question, because when you were appointed to this role, you pointed out your own faith, and you said religious priorities should be about compassion and care, and I challenge those who are putting their archaic idea of God above the needs of dying people. So that would be people like the Archbishop of Canterbury, lots of other faith leaders who are strongly against assisted dying. So you stand by the idea that it's an archaic idea of God if you have a faith objection to assisted dying.
I wouldn't quite put it like that. And remember, of course, the current Archbishop of Canterbury is against it. But of course, the previous one, Archbishop George Carey, was for it. What that shows is that there is not one monolithic view, thou shalt, but there are different views within the religious spectrum. And I actually come to my being in favour of assisted dying. By the way, as an option, that's a key word. Only if people want it. They may want to carry on to their last breath, they may want to have palliative care, they may want to have assisted dying. It's about giving people the right to decide their own death, just as we give them the right to decide their own faith. And for me, it's a matter of compassion. Why should I, if someone is suffering, like this guy kneeling on his bed, say, no, you've got to carry on for another 4 weeks because my God doesn't believe in it? Well, what about his life? What about my compassion for his rights?
Amy Proffitt, you speak for dying well. What's wrong with what Jonathan just said?
Well, just to be clear to the audience, I'm not actually a member of Dying Well. I am a palliative care doctor, and Dying Well suggested me because I am the doctor that sits at the bedside of people with life-limiting illnesses and manages their illnesses, their symptoms, their social care. I'm glad we're having this conversation. For too long, we've had opposing sides of a binary question of are you against or are you for this? It's a nonsense. It's like asking a doctor, do beta blockers work for heart failure? Well, it depends. What kind of heart failure? What kind of patient? What age? What comorbidities? This is so nuanced. What I specifically, as a doctor, am opposed to is the legislations that have been proposed in Westminster, Holyrood, the House of Keys and Jersey. The safeguards that are proposed in there are preposterous. They were the same safeguards that started in Canada and other legislations and have expanded beyond that. And why is this a doctor's mandate to do? I did not become a doctor to kill someone. Terminology here is also key. We are told the general public want this. However, it feels reminiscent of Brexit. We're polling the general public, do you want the law to change or not? But when we ask the general public what they understand by assisted dying or assisted suicide, most think it's the safe withdrawal of a treatment that might prolong or sustain life. It is not. That is already legal. Most think that it's providing end-of-life care to someone who is already dying. It is not that. People who are already in the dying phase of their life would not be eligible under the law proposed. This is a doctor providing medication at lethal doses of a combination of medicines that have never been tested in any of the legislatures. There is no research around it whatsoever to kill someone who is not already dying. That is against my Hippocratic oath and against the care I give my patients.
Can I ask you, though, that the kind of situations that Jonathan described of people in the pain and agony of a terminal illness, that people will be familiar, however sad it is, with the fact that if a family pet is in a similar circumstances, they can be put to sleep by a vet. And people think, why should humans who are more sentient have to suffer and not be able to take their own life at that point when we do that we euthanize animals all the time?
I despair every time I hear one of these stories, and I think it puts fear into the general public about people having agonizing death. It simply isn't true. We work through the physical symptoms that someone has with our skilled expertise over years of training and experience to provide relief of that suffering. Palliate itself comes from the Greek pallium, which is to cloak. That's what we do. We have the skills to do so. If I hear about people being in agony in that sense, first thing is to examine the care, not examine the law. We should want to know, what were they suffering from? Why did they not receive adequate care? Why was their pain relief not provided adequately? I am looking into a case in neighbouring trusts where someone has had a bad death because a nurse did not give medication. It's unacceptable. And I have many, many examples of the thousands of patients I have looked after that have had pain, that have had difficult symptoms, and I have worked them through with my expertise over many months to get them to end a life well, to say goodbye, to say I love you, to finish tasks and die in a manner that they would want. But by putting fear into the general public that you will have a bad death and you will suffocate and you will be in agony is not really morally right. It's fear-mongering of the worst kind, where actually as a skilled specialist and highly specialist, I can relieve those symptoms. And as we talk, I will give you some real-life examples of those patients that I have cared for that stick with me.
In practical terms now, though, many people do go to Switzerland or other places where there is assisted dying, and family members are often devastated not just by the death, but by the fear they might be criminalised by helping them or supporting them to go to Switzerland. And that surely is not a sustainable position.
No, and I think clearly we're not catering for all in this country. There are people that do want that option. But again, that option is discriminatory in itself because only a few can access it. You have to have the money to be able to travel, you have to be fit enough to travel and to do so. 320 people die every day without any access to palliative care. In Canada, where this is legal, half of the people in society cannot access palliative care. So we need to invest in the funding and access to that and grow that, whilst we decide how we sort that out of the system by coming together and having these kinds of conversations.
You said in a piece you wrote in The Spectator 2-3 years ago that the main reasons why people seek lethal drugs are often personal or social rather than clinical. What do you mean by that?
These are not requests because of an irretractable physical symptom such as pain. They are often around a loss of sense of self, a loss of meaning, and a perception of suffering, which is, in terms, what is suffering? What does suffering mean? I'm sure suffering for every single one of us in the room means something entirely different, and what is tolerable to us in our experience of ourself and our culture. These are not medical reasons, so why is it a medical duty of care that the laws proposed are a doctor to do this? Within the NHS that is already broken, with doctors that are already broken post-pandemic, and the legislation that's proposed is easily challenged as discriminatory across every single barrier. So people request it because of loss of sense of self, feeling a burden. Over half of people in Oregon stated that they wanted this because they felt a burden to a loved one. It wasn't suffering that we're hearing described in the press.
You described your relationship with the Dying Well group, but the parliamentary group, and I think you've been clear that faith is not an issue, you're talking as a doctor here, but the people in the Dying Well group in Parliament, Danny Kruger, David Alton, Tim Farron, Stephen Timms, are all pretty much known for their strength of their religious views. So you accept, presumably, that a lot of the people opposing this are doing it because of their faith.
I don't question anyone's motive in this, whether it's faith-based, whether it's the good motives of those that want to see the law to change. I think we're all looking for the same outcome in the end, and that's the relief of suffering, whichever type of suffering it is. But when it becomes backed into this argument about you're only opposing because of your religious faith, it becomes complicated. I remember around the time I wrote this article in The Spectator, I was called by a member of Dignity in Dying as a swivel-eyed loon and a religious zealot. I've checked with a neurologist, my eyes are fine, my mental health is good, and I'm agnostic. So my views are not, and most people's views are intrinsically to the core question, not about particular perspectives on the views of life.
Okay. I very much want you to cross-question each other in a moment or two, but let me bring in Zoe Fritz. And I mean, nobody is truly neutral in this argument, but as another medical practitioner, where do you think the profession is on this? Where's the balance of view among doctors about what the right thing to do is?
So I obviously can't speak for all doctors, but doctors have been polled a lot, and most of the Royal Colleges have now adopted a neutrality stance. In other words, they're not actively supporting or actively opposing it. I think there are a couple of things I'd like to pick out, because although this is not a debate, and I don't want to spend time kind of doing rhetoric or defining things, I think there are a couple of things in there that mean I need to explore a little bit more before we go into what doctors think. So I think the question of, is this, when people are asked whether doctors want to support assisted suicide, you have to separate out whether we want to support the right for individuals to have assisted suicide and whether we want to support the involvement of doctors in facilitating that right. And I think that's critical. And I think most doctors support individuals' right to have assisted suicide, whether it be because they are physically suffering, and I absolutely agree with Amy that palliative care should provide a way of diminishing suffering. So I do acute medicine, but I look after a lot of dying patients, and I'm happy to say that most of us can make the actual process of dying pain-free, not breathless. We have the right tools to be able to help that. Can we make it a lovely experience always? Absolutely not. Can we make sure that it's happening at a time of someone's choice, with their family there in a place they want to have it? Most of the time, not. So saying that you're going to legalise assisted suicide to doctors might mean, well, we might have fewer patients who have a death that they don't want. It's about providing autonomy. And then the second question is, should doctors be involved in doing that? And doctors are very conflicted about that, and they're conflicted about that for several reasons. One, as Amy said, we've started off by saying do no harm, and it's kind of hard to think of a way of prescribing a drug that will cause death as not doing harm. You can have a debate about it. You can make an argument that there's not much difference between an act and an omission and not giving treatment and so on. But it's hard to say it's not doing harm. And secondly, I think a lot of people are very concerned that it will interrupt the relationship between the patient and the doctor. And it will interrupt the relationship between which patient chooses which doctor. So, for example, if you know that some doctors are able to provide assisted suicide and are willing to do it, whilst others are conscientiously objecting to it, is that going to make a patient a little bit untrusting of that particular doctor if they think, oh, well, maybe they're likely to do that? So I guess my main point is you need to distinguish between the right of an individual to have it and the role that a doctor plays in it. And I think they're two different questions.
But we are talking about something clearly new, aren't we? Because doctors play God in that they can turn off a life support machine, or they can withdraw, in some cases, hydration or nutrition. This is saying that if you get a diagnosis that says you have 6 months to live, you can say at that point, I'd like you to kill me now. And that is a very fundamental change, correct?
Yes, and I'm saying I don't think doctors should be in that position. But I actually,
well, I was going to say I read some of the things you've written in which you imply that courts and lawyers should be more involved.
So
isn't that passing the buck a bit?
Well, I think it's asking the correct people to do it. So actually, if you look at withdrawal of assisted nutrition and hydration in a patient with a persistent vegetative state or a minimally conscious state, that has to go to the court of protection. So until literally a year and a half ago, 2 years ago, I've forgotten now, since the case of Tony Bland, I'm sure many of you remember, so he was in a persistent vegetative state. There was a question about he had no sentence, but he was being kept alive. He didn't organ support, but he was being kept alive with artificial nutrition hydration. And the decision was that this was not in his best interests. Artificial nutrition hydration was stopped with the inevitable consequence of death. And between then and now, about 100 cases have gone to the court of protection, where the family presents the case, you have doctors there as expert witnesses, and a judge whose job it is to weigh evidence then decides whether there's any hope of any recovery, whether they think this is in that person's best interest, and makes a decision. So that's what's happened with withdrawal of nutrition hydration.
Can I just ask you, though, that the numbers are quite different, aren't they? So in Canada, I think, 40,000 people have died through euthanasia in the 6 years of legislation. So in the UK, that would be more than 100,000 people in that period, with the number in Canada going up. So, I mean, it's not...
It's not analogous, no, and you would clearly need to think about how, and in fact, as I say, they've changed things in the Court of Protection because you don't want to create a scenario that's clogging the courts instead of clogging the doctors. But I do think you could say there's a situation where you have a judge or a lawyer who is considering the evidence that the person is in a fixed, the safeguards that all of us are talking about. I think we all want to make sure that there are safeguards here, that an individual who makes this decision is in a fixed state of mind, that they're not under undue pressure, that they're not doing it because someone else wants them to, that there isn't something reversible, that a doctor hasn't, that they do have a proper understanding of their medical condition rather than there being something reversible or a treatment you can give them. So that kind of wider spectrum is not something that we are actually trained necessarily to do. We're trained in very small ways, but I accept that it's asking for expert advice, but I don't think that's the same as passing the buck.
Okay. Let me ask you a final question as well, which is that reading some of the debates about this, there is an argument that says the more euthanasia you have, the less good palliative care you have in the country. Is that true?
So I don't think that's true. And I think, Amy will know more, but there's been quite a lot of assessment of evidence as to whether palliative care, either the training of it or the research into it or the provision of it, decreases when you say there's an alternative, which is assisted suicide or euthanasia. And I don't think that's the case. I do think it's the case that in any situation where you introduce assisted suicide, you need to have really good prospective research following it. You need to say, who is it happening to? What is happening to palliative care? What are the unintended consequences? What are the consequences of the treatments that are being given? So Amy mentioned we haven't really looked at the impact of the different drugs that have been given. Are there any patients that are suffering when that happens? There's very poor evidence on that. So your direct answer is no, I don't think that's the case. I think that, you need to make sure that palliative care provision is separated from the provision of assisted suicide, and that actually built into any plan to introduce assisted suicide is a plan to really make sure training and awareness of palliative care is provided.
Jonathan, you heard Amy's arguments pretty intransigently against what you are arguing for. What did you make of them?
Well, I think, first of all, I have to say it's wonderful there are people like Amy who are doing the job she's doing, and all credit to you for devoting your life to helping people. I'm not arguing at all against that. I'm arguing for help people who want to be helped, but let people go who want to. And actually, language is important here, isn't it? I mean, you said, or somebody said, asking a doctor to kill you. That sounds, not very nice at all, but asking a doctor to help me, relieve me of my pain is very different, isn't it? It's much more gentle, and it's also putting all the emphasis on the patient. And it's saying it's actually the patient's choice, not the doctor's choice. And actually, I would take up this idea of doctors being against, in the sense that actually most people in hospital ask their doctor, can't you do anything to help me? I remember just a couple of weeks ago, seeing someone who said to me, every night I pray that I won't wake up in the morning, and every morning I'm disappointed. And of course, there would be a conscientious objection clause that any doctor who didn't want to be involved in it wouldn't have to do so. And to say there's no agonizing death, well, gosh, I would really contradict that of all the people that I've seen. Some people die very happily, other people die in great pain. That's the whole point. And to say that this has never been tested before, when I just said that we've got 25 years of very well documented experience in Oregon, is also a little bit astonishing. But what you did say is that, I quote you, people want that option. So doesn't it border, I don't want to use the word on arrogant, but controlling on your part to say, oh no, you can't, oh no, you shouldn't? Why are we denying people the right? And I suppose that's my question to you.
Amy,
don't we have the... don't people have a right to choose, if they are dying anyway, to die well rather than to die badly?
Okay, let me unpick some of that for you. I never said people don't have an agonising death. Actually, what I said is if that happens, you must examine the care that was given. It clearly was incompetent, inadequate, or poor, or they lacked the right resources to help them. You shouldn't change the law on the basis of that. You should examine why that care was so bad that should never happen, but it does, and it's unacceptable. I'd like to unpick the term rights and autonomy. I think you mentioned autonomy as well. Autonomy is always restricted, and it's restricted for a reason. So who is truly autonomous here? Who has the right to govern everything? My argument would be the only person who has ever had the right to self-govern was Robinson Crusoe, because he sat on an island by himself. When Man Friday comes along, the system changes. So what if Man Friday decides to cut down the tree at the middle of the night because he's cold and I want to build a fire and warm myself? And the next day, the sun beating down burns Robinson Crusoe so badly that he sustains burns and doesn't survive through dehydration. We impact each other's autonomy, and autonomy is restricted. And we know as society, particularly health restrictions and autonomy, are required. And we accept that. Did we not, in the pandemic, stay home? Did we not protect the vulnerable, the elderly, the disabled in society, those with learning disabilities, to protect those people? And the law as it stands is designed to protect those very people, those who are vulnerable, those who are elderly, those with long-term conditions. We already put limitations on freedoms before, and we acknowledge that. But what of the safeguards that are proposed? And as I say, it's not about the right to choose or choices that I oppose. It's about the law that we have suggested in this country that has been put forward. So the safeguards, if we explain the law to you for those that may not have seen it, you need to be able to be voluntary. This has to be your own idea. You should have a diagnosis of around 6 months of a terminal illness, and you must be able to take the medication yourself.
That's a great summary, but rather than say what's wrong, why didn't you say what you would like to introduce and therefore
I will
make
do,
it possible?
if you let me come to it. So first of all, voluntary. As Zoe says, I can't determine as a doctor coercion. I'm not a lawyer, I'm not a solicitor. I, by my very compassion, sit at the bedside and I want to help someone. So if someone tells me they're suffering or they're in pain or they want this, I try to find a way to help them. There are family disagreements in every patient that I look after. People disputing over wills, over financial abuse, over they should have this care, no, they don't want this, they don't want to die, they do want to stay alive. I can't determine family coercion, but I equally can't determine NHS coercion. I've spoken to patients in Canada that have been told they can't have a wheelchair because it's too expensive and it will take too long. You can't have palliative care because it's too expensive and it will take too long. But you can have medical assistance in dying. It saved the healthcare system in Canada $180 million a year. And I worry about the health economics and how that might be misused in this country, given we saw in Brexit the big red bus with the $350 million for the NHS. We've got an NHS that's poorly funded, poorly staffed, on its knees. What is the risk of this being seen as a health-saving cost? But what of the 6 months terminal diagnosis? As a doctor, that is impossible. William Osler is one of the 4 founders of medicine, and he said that medicine is the science of uncertainty and the art of probability. We cannot determine 6 months. It's impossible. We know people that live many, many years beyond a 6 month prognosis itself, or others that are told have many years and die overnight. As a palliative care consultant, sometimes I get it wrong. And it isn't that discriminatory. What if I've been told I've got 7 months or 8? What of a year? What of 2 years? What of 5? So in Canada, the terminal diagnosis was removed because it's a nonsense. And who is to say that suffering from a terminal diagnosis is worse than suffering from a mental health disorder and that their suffering is any less weighted? So then in Canada, it became available for those with a primary and sole mental health disorder. And then what about the age limits? The age limits as a safeguard were removed and seen as discriminatory. So there's Bill C-17 going through in Canada to remove the age limit down.
Why are you
to
talking about
competent
Canada?
12-year-olds.
Why don't you talk about Britain?
Because it's the same legislation.
Okay. If you're going to talk about foreign policy, why don't you talk about Oregon?
Okay, I can talk about Oregon. Let me first explain the safeguards.
More importantly, I think the audience would like to know, are you against this in principle, whatever, or are you actually against it in practical? If they're
Let me
practical...
come to that then. If I can speak to the safeguards proposed in the UK were the same ones in Canada. In the 7 years, they've widened out beyond that and dropped the age limit to 12. In Netherlands, the age limit is 12. In Belgium, there is no age limit, so a neonate. My daughter's 12. She might have a mental health disorder. Would I want her to go through this? No. So, if you imagine the Hoover Dam being the safeguards proposed in the law in Britain, and you find that these are discriminatory and they can be legally challenged, you would have to drive a hole through that dam to allow access for that individual. Okay, so mental health disorder, you're discriminating against me, will drive a hole. Age limits will drive a hole through. If you drive through holes through those barriers and the safeguards, eventually the flood comes and the barrier falls down. And that is why the law that has been proposed is insufficient and harms the doctors as well.
And now your positive suggestions.
So when you asked me about Oregon and the evidence there, Oregon destroy all their data after 1 year. So we don't have 25 years data. They write a one-off report.
Of course we do. Of course we do. They're actually physically there. I mean, that is actually misleading the audience horribly. I have to say.
They write their reports, the reports are there, but the actual data isn't.
But the reports are cumulatively there, so we do have 25 years of data. I think
okay, if I've got that wrong, I will apologise. But my understanding, talking to the doctors in Oregon,
I think that undermines a lot of what you've said, to be honest.
I don't think that's very respectful, with all respect.
Okay, can I just ask? Well, I think the VC and I will bring the audience in just a moment or two. Can I just ask you a question, Zoe, as trying to arbitrate on, although you're both medical specialists, the thing about how long a diagnosis is. Do you think that a 6 month deadline or prognosis is realistic? Does it mean
I don't think it's very helpful. So I actually think the question, and I'm sorry if because I think this isn't a debate, this is a general question. So I don't think the question, I think the question should be about whether assisted suicide is the right thing that people should have the right to, not necessarily at a 6 month prognosis, because I think it is incredibly difficult to estimate. And I actually think a lot of the people who are suffering have, and a lot of the people that have gone through the courts in the UK to ask for assisted suicide, or in fact for euthanasia, have been patients who have had other kinds of conditions. So, for example, motor neuron disease, which might have a much longer, much more difficult prognosis to work out. MS, there have been famous cases in the UK of patients with MS who've wanted to have assisted suicide or have protection against making sure that their loved ones aren't prosecuted if they do attempt to have assisted suicide. There's a patient who's had a significant stroke, who's very debilitated, who says, I just want to be able to know that I have control. When I get fed up, I want to be able to know that I can end this rather than just waiting my time out. I don't want to have to starve myself to death. So I don't think it's easy to predict 6 months. You can have a good guess at it, and I don't think it's necessarily a helpful limitation to have. Can I add something else that hasn't been
Yes, of
brought
course.
in? So I just wanted to say, I think there's an injustice at the moment in that people are, because we don't have legislation that allows assisted suicide, so you've talked about people going to Switzerland and how that's inequitous because you need quite a lot of money and quite a lot of support, and actually family who aren't worried about being prosecuted when you come back. So we've had I think 179 families prosecuted for taking their families to Switzerland. And then we have something that doctors do see, which is actually botched attempted suicides, which are really miserable. And I guess I've got my story to tell as well, which was of an elderly lady who was in fact a doctor herself, who had made a very clear and settled decision over a long period that she wanted to end her life for various reasons, medical as well as non-medical. And unfortunately, it was, well, unfortunately, I say unfortunately because I saw how devastated she was when it didn't work and what grief she'd caused her children and how she had actually wanted to do it with her children there. And you just see, this is one of the few statistics I wrote down. So there are about 650 dying citizens who attempt to take their own lives every year, or who successfully take their own lives, with another approximately 3,000 who are trying to do so. So as doctors, we see that this is going on, and that's actually also an incredibly difficult thing to deal with.
I think the VC and I are now going to do a double act. So, VC, if you'd like to choose people to ask questions or make comments, and I will throw this microphone into the...
Oh, you have one of the throwing ones. Yes, I love those. Okay. So who has a question from the audience for any or all of our speakers?
Or we can keep going with the panel. Any immediate questions?
There you go.
It's coming in.
Okay, can you hear me?
Yes.
Okay, so I'm a second-year medical student, which meant I had the privilege of being taught by Dr. Fritz last year on autonomy. And one of the critical parts of autonomy is that you're not coerced into it. How could the law try and make sure that financial coercion or the feeling that you're a burden to your family is not part of someone's decision to take their own, well, to undergo, have the right to die, and to choose that? So what legal restrictions would there be around it? How, as a doctor or as a lawyer, as a solicitor, can I make sure that the patient hasn't been coerced? Because, I mean, my feeling of it is if I'd rather 10 people don't have the right to die than one person dies whilst being coerced by other factors around them, or maybe that choice isn't 100% their choice.
Jonathan?
Actually, I'm interested in your statistic. 10 people die in pain, one not, but...
No, that wasn't a statistic. That was more, I would, as a doctor,
Yeah.
I mean, as like...
Yeah, no, your personal statistic, which I'm not sure if I agree with or disagree with, but it's an interesting statistic. Well, what the proposed bills try and do is exactly that, because, I mean, the object is not to kill people. The object is actually to keep people alive. And here I want to agree with a couple of things that Amy said. People should have good palliative care. And those of us who are in favour of assisted dying, or the right to an assisted death, are also very much in favour of palliative care. People should have a whole menu of different options. And it's interesting that actually, certainly in the States and in Australia, which I know better, the funding for palliative care has gone up. And certainly in Oregon, the palliative care people who were initially, I have to say, are very much against assisted dying being introduced, now that it's there, work together quite side by side with it. I'd also like to agree with you that it is discriminatory that people have to go to Switzerland, because it means, A, it's only the richer people, and also it means you have to go before you want to, because you have to be well enough to get on a plane, rather than do it fairly last minute, if you've got MSM or whatever, Parkinson's, and do it at home, just sitting in your armchair. But to answer your question, what we're trying to say in the legislation And this is why I was pushing Amy to make positive suggestions, because they're welcome. I mean, you know, this is a team effort. We want to get it right, not just for the doctor, but for the patients and the family. Is that, for instance, the person has to be interviewed by an independent doctor, not the family doctor, and then have a second interview by another doctor, and it has to be, they have to be both certain that the person not only has got the diagnosis, 6 months or roughly, but is clearly terminally ill, and so it has to be independently assessed by two people. They have to make a written declaration. It has to be overseen by a judge. And of course, they can change their mind at any time. All assisted dying does is allows them to get from the pharmacist the potion, which they can then leave or not take at all. And again, what's interesting in Oregon is a lot of people apply for the right for an assisted death, and only a small percentage actually take it, because most of us want to have that safety net, that if things go pear-shaped, then we've got that option. But actually, most of us will actually carry on to our last breath and live as long as possible.
Amy?
Brilliant question. I say that I'm trying to move away from this binary yes or no, but I think what you've hit the nail on the head is the only binary question maybe, is it better to not kill someone who wants to die or to kill someone who might want to live? And I think there are options if, I say, Dr. Romain was pushing me to, am I in principle in favour or against? This isn't about principle, this is about the law that's proposed. And I think if we're wanting to make a safe system so it's not discriminatory, is that we put it into a civic model. We look at a model that does have lawyers, does have solicitors there. A doctor can give expert witness on their view of the trajectory of that illness itself, but that should be someone who's an expert in that field of that illness, not a doctor who's never met them before, and then a second doctor who also hasn't met them before. And that there are modalities to do it where actually a court could mandate, yes, we agree that this is not coercion, this is free choice. We've had an expert witness doctor suggest the way that this might work, and the court can then release the medication through a modality. Then we can regulate it. Then we can research to make sure people aren't having some cognitive awareness as they're dying, and actually are the curare drugs that are used in some settings making someone paralysed and they can't even tell you, I'm awake and I'm experiencing everything here and I'm asphyxiating. We need to do that kind of research and regulation and actually look at the proposed models in different settings where it sits completely outside of healthcare. It's not for the NHS, which it could erode, and it sits hermetically sealed outside a doctor's duty of care as a treatment for suffering almost.
Can I ask you the reverse of the slippery slope question I asked Jonathan, though?
Yes.
Which is that the countries which have this legislation do, in the end, with popular and political consent, liberalise it further. Yes. So your incredibly restricted approach is not the one, in the end, that countries democratically choose to opt for.
Yeah, I think, as Jonathan points out, you know, none of the legislations have taken it back, because I think once you've gone down that route, you can't go back again. So then it becomes the discriminatory things of, like, that's not available for me. I am paralysed from a C-spine injury and I want to die. I don't have a terminal illness of 6 months, so I don't fit in that criteria. I can't administer the medication. You're going to have to inject it for me myself, which becomes bordering on euthanasia in itself. But if you regulate it in this way, instead of those few people that can go to Switzerland and have the money for it and the sense and the societal and family build-up around them, that makes it an opportunity. And I work in the borough of Newham. People don't speak English, they don't have money, they're the most socially deprived people that are in the country. None of this is accessible to them in any way. And then they've got the cultural differences around their perception of death and dying. So maybe there is a way, and this is the start of the conversation, rather than you're against and you're for and we're going head to head and I've won. How do we sit at the same table and go, right, what do we do about this? In principle, if you want to talk principles, we want people to have a good death and a good life and live to the end and live well to the end. So we've got to join forces, surely.
So if you were, just to follow up what you replied, if this was moved into the civic domain and you had legal and solicitors' involvement and you could put that, enshrine that in law, then in principle you would feel happier about it?
I would feel happier provided it is constantly regulated, double-checked, and we know that it's not. One thing I do want to mention is morbidity for doctors. More than one doctor every week commits suicide. If you cut me, do I not bleed? And people feel morbidity, mortality. As a doctor having to do this, and I've spoken to doctors in Canada, I've spoken to doctors in Oregon, what does this feel like to you? Doctors saw an awful lot of death and dying during the pandemic. I personally, in the first wave, dealt with 770 community unexpected deaths from COVID, wrapping bodies, seeing them in mortuaries. We're on our knees with our workforce. This isn't for healthcare. This is not for doctors. Let's find another solution.
Interesting that, because all the countries in the world have gone through the medical route. And it's like, well, actually, why don't we try and improve the existing model rather than create an entirely new model devoid of medical invention? That just seems a bit logically...
Dignitas sits outside of the healthcare model. It's not within their healthcare system like the NHS. And that's successful, I think. I think people have had good experiences from that.
Let's see if we have another question, or do you want to, Zoe, do you want to
I was
come?
going to say, I think the reason for looking at it on its head is because although there have been things that have been good about it, there have also been problems. And I think if you talk to the medical professionals who are involved, there have been problems, and we've also seen that in some places it's been effective, and in other places it hasn't. And Oregon is a really interesting example, but it is for patients with terminal illness. And I think, if we're going to talk about autonomy as one of the reasons for this, then I do think my view, and my medical view as well, so as ethicist and medic, would be that we'd have to spread outside that. We have to talk about other people who have, as I say, MS or MND or something, who want to have control over that. And so I think we should be thinking outside the box and saying, okay, well, here have been the issues in other areas. How can we protect medical professionals? How can we protect autonomy? I thought your question is excellent. How do you make sure someone doesn't die who doesn't want to? It's a question we have to ask all the time about, finishing treatment when patients don't want treatments as well. How do you make sure someone isn't coerced? So we do that when we're saying, okay, we won't do treatments.
Can you get the microphone further along your row to just wave your hand there, and Tissat will try to...
Yeah. I don't know much about this topic. I'm not a doctor. I've been in medical research, but my question is more, obviously there's an important issue, which is talking about the kind of devastation or strong impact it has on the doctors. And without knowing any about how this assisted suing process works in any country, I was just wondering, do you envision in part of the hypothetical solution, because you mentioned about the patients have to volunteer to be able to take the medicine themselves. So is a possible solution in terms of trying to offset the devastation to the doctors, do you have the doctors be a part of maybe the jury with the legal side to assure that it should happen, but then maybe it should go through a third party of, I don't know if there's a dispensary, or so whether the doctor actually has to be there to give the medicine, if by that stage all of the hard decisions have been made, is that a possible avenue of the system?
Zoe, that question.
Yeah, so in Oregon, there is a prescription for the drug, and the doctor doesn't need to be there. So so the prescription's there, patients have it, and as has been said, a lot of them don't take it. It's the knowledge that they have control if they want to that's there. What hasn't been tested out is whether there's no system where a non-doctor could prescribe it, but it's theoretically possible. You could say we're going to legislate for a situation where all this happens, and the medication, I think we can think outside the box, not that box, but a different box, yeah. And so I think it's theoretically possible. There are situations where patients aren't able to do everything themselves, and I think that is a different question. So I think we are very clearly just talking about assisted suicide, where you do something and then the patient takes the drug themselves.
Okay, we have other questions. I think. Can you
There's
throw
one right
over
behind you.
You could just hand there. Sorry. We're going to get
Thank
to
you
next.
for this very thought-provoking panel discussion. And I'm currently visiting research fellow at CRASH. And I'd like to share some experience from Australia, because I'm visiting here from Australia. So in Australia, we also have a nationwide campaign to garner the popular support of voluntary assisted dying, especially in WA, that is Western Australia. And in order to do this campaign, there is an NGO called Go Gentle Australia. And this NGO organization is like an advisory committee and health promotion charity. They try to spark the better conversation about this very controversial issue. And in that campaign, they are using the argument, which is they don't see death as a right, or it's not necessarily about the right to die or the right to die well. they use the frame like see death as a choice of end of life choice. So that's why they're calling for the national awareness. If they really want to have an end of life choice, they need to add a voice to this initiative. So they produced a few campaign videos, including one is called Stop Horror. And that is like a 3-minute horror movie or documentary. And it's so terrifying that it's even unwatchable. Most people just stop at like 59 seconds. They can't finish the whole campaign video. So my question is really about, because I know all of you are talking about this controversial issue from the expert perspective, but for the lay people, what's your view or reflection on this, especially how the communication should be done to communicate with the lay people so that they can improve their understanding of the voluntary assisted dying so that they can make informed decision and even participate in the debate in a more meaningful way?
Shall we, that was a very good point. Shall we take a question down here as well? I think you were signalling there. And
I wanted to ask about perhaps, well, I found it very interesting hearing your points, and I'm interested in whether perhaps the fracture in beliefs here is based on how the public and doctors actually view the role of the medical profession. I wonder if part of the issue in difference in opinion is based on the fact that some people perhaps increasingly view medicine and doctors as providers of a suite of services that they get to choose from, whereas others might have a more traditional view of medicine, wherein there is a slightly different power dynamic, or just a slightly different dynamic, full stop, and the doctor is an expert who prescribes treatment in response to need. And I wonder if it's actually perhaps a difference in opinion based on what the purpose of medicine is actually for that maybe hasn't been talked about enough among professionals or the public that is at the heart of this debate. What do you think?
Both really excellent questions. I'll come to you first. I think you're completely right what you say in terms of the layperson owning this conversation. If this sits with society because it's societal issues and not medical, then the debate needs to sit in society. I mean, Jonathan and I's views are known, practiced and polished, and us talking to each other doesn't move us forward as society in terms of this, and it's got to sit with everybody, and it's got to be in that wider sphere. With regards to your question about doctors, I think you're completely right. I think there's been a shift in medicine, even in my 20 years as a doctor, and good we got away from paternalistic healthcare that you will do as I tell you, and you will, and it's shared decision making. But there's also a shift in society around the difference between what are rights, choices, and preferences. And you know what we're talking about here is choice, not right. It's the ability to have that, but it's negotiating that carefully with your health professionals, with those that look after you, with your family, with your loved ones, with everyone that matters to you. And that's why I say autonomy is relational, because it's this web that goes out across all of us in society. And I think it's important to have those discussions. And as Jonathan says, people do come to me as a doctor and say to me, I've had enough of suffering, and why can't you just end it all? And it's my duty and responsibility to sit down and say, what's making you feel like that? What can I change today to make something different? And have that conversation. I mentioned earlier a patient that had been very clear about his wishes and his choices and that negotiation. I had a 31-year-old with an adrenal cortical, there's a renal cancer. He was end-stage disease, he'd progressed through his treatment, he'd been diagnosed for 2 years. And I worked for him for a period of 2 months, and right at the beginning he had physical pain. He had, and I apologise if this is upsetting to anyone's personal experiences, more than the effects the cancer had had on his body, so loss of weight, loss of energy, sleepiness. He wanted to live, but also wanted to die at the same time, and it was hard to reconcile those two things. On the one hand, the biggest suffering for him was this is not fair. 31, and I remember him saying to me, I should be in the pub with my mates. I should be travelling around Thailand. I should be living my life. And he decided he wanted to write a blog of his experience. And I worked with him with my expertise in palliative medicine, using medicines like methylphenidate to keep him awake enough during the day to write his blog and have enough energy to work out the discord between him and his family. Mum struggling, I'm having to go bury my son. Him struggling with, like, Mum's, leave me alone, you don't know what it's like to die. And they'd broken apart. So I spent a lot of time and expertise dealing with the family, with him, used the medications to get rid of his physical pain, help with the symptoms, write his blog. And on the day he died, his blog was published in a national newspaper, by coincidence, not by design. And he talked in that blog of the privilege of having lived to the end and have a natural death and watch his family and friends come to understand mortality. We are all going to die. It's the only epidemiology of 100%. It will affect all of us. And encouraging people to say, I love you, to go travelling, to live life, to do the things that you want when you can, but to also acknowledge that acceptance that he came of the privilege of the last 2 years that he never thought he'd say when he got diagnosed. Had this been legal in the system at that time, I would have been obliged to refer him on for assisted dying, assisted suicide, and he would never have reached that acceptance. His relationship with his mother and sister would never have repaired. And he ended life well. You know, he sent a message out there nationally to say the importance of acceptance of dying and, in a sense, a different way of letting go. And I know for certain, had it been legal in the country at that time, he would be dead before he got to that acceptance. And that's the privilege of my job.
Jonathan.
Well, that's a lovely story. And he's a very lucky man to have died in the way he did and to have you looking after him, so well done. I suppose my caveat is that what you did there was absolutely right, but just because it was right for him may not be right for everyone else, and different people may want different options. So to answer the two questions, Australia, yeah, it sounds a horrendous video, gosh. And certainly and Dignity in Dying is not, we're not campaigning for people to have an assisted death, we're campaigning for people to have the option of an assisted death if they want. That's a very important difference. And I would stress, what we want to do is have a British law that's suitable for us. So it's okay to talk about what happens in Oregon or Netherlands or wherever. Let's use the experience of all those other places to fashion the best possible, the tightest regulated, the most accountable, the most transparent type of system that takes into all the genuine worries and to get it right. And as for the doctors, yeah, I mean, I think, and you correct me if I'm wrong, both of you, that doctors no longer take the Hippocratic Oath, which says, thou shalt do no harm, but they take the Geneva Convention, which says to act in the best interests of their patients. And of course, that's slightly different. And it may be for some people, their best interest may be to have the option of an assisted death. And I'm glad we clarified that doctors don't actually have to be involved at the very moment. They have to give the assessment, give the prescription, it goes to a pharmacist, and then the person will take it, hopefully, in their own lounge, sitting with their dog, with their parents around them, listening to their favourite record, and that's quite a nice way to go, if you want it.
Debbie, we've got about 5 minutes left. I'll let you steer us through closing arguments, if you like.
Closing arguments. So I would like to give, I guess, a question would be, what thoughts do you have at the end? And I realize that you are all very practiced in these, but what would you say we've come to? What do we know now that we didn't know at the beginning of this conversation? Let's start with Zoe.
So I think you said, is it compassionate or dangerous at the beginning? And I think we've all shown that we are compassionate in wanting to have what is good for patients and for the population. And I think where we've come to is that I would say we all agree that patients should, in theory, in some way, have some autonomy. We'd like to be able to create a world in which we could do that with absolute confidence that it wasn't going to spread. I think those are some of the anxieties. And while this is adding something and not just summing up, you've mentioned some of the things, so I don't want to repeat it, but for example, you could say we're going to make sure there wasn't going to be, that patients had suicide prevention interventions, that there was legal, external stuff to make sure there was no pressure, but essentially that you'd have, we would say we want it, and maybe that would address your question of there's 50,000 in Canada. If we actually say we're going to have this really tightly regulated, there aren't going to be, because people won't, they'll have many more checks that these things aren't going to be quite like that. So I think we share compassion and we share a desire for really good regulation, and perhaps we share a belief that if as a society we can talk about it openly, then we can prevent a kind of slippery slope, because my view is that if you really talk through the slippery slope and you're really open about it, then you put the safeguards in place in advance. That's part of what you do. Maybe that's optimistic of what we've all come to, but that's where I would stop.
Amy?
I agree with Zoe. I think in a sense, there has never been a question of the motives of anyone on any side of any discussion around this. I think ultimately, nobody wants someone to have a bad death and to suffer, be that from me providing the care that I can provide as described, or allowing open discussion. I think that's really important. And I agree with the young lady from Australia about pushing this back out to society to discuss, provided they know what it is that they're discussing and what it is that they're voting on, rather than just asking the public, do you want it or do you not? Well, you don't really understand, a bit like Brexit, what it means at the end of the day.
And Jonathan?
Well, I've learnt from Amy that she doesn't come from a fixed position, which is interesting, because you said that if such and such happened and this was happening and that was happening, it was legislation, then you would not be quite so opposed to it, which is different from the main opposition groups, Dying Well and Care Not Killing, which are largely religiously based, which are largely not just anti-assisted dying, but anti-abortion, and they come from a certain ideological place, which is not going to shift, whereas you seemed to come from well, let's see if we can make it better, and if we can, then I'm in favour, and if we can't, then I'm not, which is actually something one can work with and go forward with.
Okay. Roger, any parting words?
No, I think those were extremely interesting conclusions.
Yeah, my parting words would just be words of thanks to you all. That was fascinating. That was really interesting. And I think for all of us in the audience, I learned, I hope you all learned. And my views evolved even as we were talking, so I'm sort of sad it's over. But I just want to thank all three of our presenters and our host, Roger, for welcoming us into Selwyn. Feel free to
I thought it was a good
down,
evening.
chat. Are you ready? No.